All right, I guess we can go ahead and get started. Welcome to everyone in the room and everyone on Zoom. It's really a particular pleasure for me to have Dr. Brad Maron here today. Let me tell you a little bit about him. He received his undergraduate degree from Williams College and his MD from Brown. He did his internship and residency at Boston University and senior residency at the Brigham with doctors Lascalzo and Leopold, and was then a cardiology fellow. That's when I first met him, and it was already very clear at that point he was a superstar destined for great things. Really, even at that stage, just remarkable how strong he was as a fellow in terms of clinical aptitude, in terms of research, just very, very impressive. And then when I was actually chief of cardiology at the VA, I recruited him to head up and start a pulmonary hypertension program, a collaborative program between cardiology and pulmonary medicine, where again, he did an exceptional job putting together a strong clinical program and an exceptional research program. And not only was there just a great clinical and research activity on site, he also used the National VA database to redefine what pulmonary hypertension is, dropping the thresholds from what they previously were, a really seminal contribution to the field that lives on. I mean, for the fellows, the pulmonary hypertension cutoff you use are the ones that Dr. Maron defined, taking the levels low, just like, LDL levels dropping, blood pressure levels dropping in terms of what's normal. Same thing as what he did back then with pulmonary hypertension. He rose up through the ranks to become an associate professor at Harvard Medical School, and then was recruited away to the University of Maryland, where he is now serving multiple leadership roles. He's the senior associate dean for precision medicine, the Melvin Shiraki Professor of Medicine, an executive co-director of the University of Maryland Institute for Health Computing, and the director of the Pulmonary Hypertension Clinic, or center, I should say, really. So a number of leadership roles at the University of Maryland in cardiology, outside cardiology, institutionally. And he's also, as you may know, the incoming editor-in-chief of Circulation. And I'm confident he'll take that journal to even greater heights. And, after his lecture, we will have a reception. So for any of you that are hoping to get things published in Circulation, now's your chance to earn a few points with the incoming editor. So take advantage of that opportunity. His research really intersects multiple different areas: redox, biochemistry, network medicine, next generation bioinformatics. And his goal is really to discover novel mechanisms that underpin cardiovascular disease. He's led multiple collaborative projects contributing to drug development, epidemiologic reports establishing cardiovascular risk, really many different areas, pragmatic trials. That's an effort that he's leading at the University of Maryland. He still has his basic science laboratories, truly a Renaissance cardiologist and physician, doing everything and excelling at all those tasks. He's co-authored over 220 manuscripts, holds co-inventorship on several innovations. He's funded by the NIH, several other organizations. He's the president of the Pulmonary Vascular Research Institute, a member of ASCI, and a recipient of numerous awards that include the Thomas Smith Fellowship Award from the Brigham, named after the late Thomas Smith, the Lerner Research Young Investigator Award from the Brigham, the Excellence in Tutoring Award from Harvard Medical School for several different years, the Eleanor and Miles Shore Scholar in Medicine from Harvard Medical School, the Department of Medicine Chair Research Award from the Brigham, the Young Physician Scientist Award from the American Society of Clinical Investigation, and the Career Achievement Award from the Pulmonary Vascular Research Institute, as well as the Distinguished Master Clinician Award from the Brigham. So really a series of awards that are tough to get and very meaningful from the Brigham and Harvard Medical School and a variety of other institutions. It's really a privilege to have him here as the Simon Dack Lecturer, and he's going to talk about pulmonary hypertension and AI's role in it. And I know I'm very interested in that topic, and you'll see he's a dynamic lecturer. I'm sure you'll enjoy it. Dr. Maron.
Well, Dr. Bott, that was an incredibly warm and kind introduction. Thank you very much. I wanted to first start by acknowledging how important and how inspiring Mount Sinai has been to me over the years through the literature and through personal interactions. I'd say most recently the opportunity to meet Dr. Maron, who shares phonetically my last name, so that's good, has really been inspiring, and I had a chance to meet you for the first time, and I appreciate the conversations we've had together. Of course, Dr. Bott gave me my first clinical job, and I'll always be forever in debt to your confidence in me. And then today I had a chance to meet and talk with Dr. Fuster, and that was, of course, a monumental and transformative moment, in part because it tells a continuation of the story that I think the lecture here today began in 1983. And this is a picture of Dr. Dack, and I was really humbled to have a chance to go back in time and read about his seminal contributions to cardiovascular medicine at large. He was, of course, the first editor-in-chief of Jack. This is the first masthead of the first edition of Jack, which I believe was in January of 1983. I was warmed to see some people on this list whose names are familiar to me. And it was with substantial gravity and pause that I realized that Dr. Fuster, of course, was the immediate past editor-in-chief. And as I roll into my role at a journal, I'm excited to be leading circulation. And I took advice today with great heart. So thank you again for the invitation. Similarly, to understand how we got to where we are today in pulmonary arterial hypertension, it's important to always go back in time and remember a little bit and recognize the sequence of events that got us here today. So the first standardized definition of pH was published by the World Health Organization in 1973. And this was really, as I dove into the story and talked to some of the few folks that I was able to connect with who were there, the consequence of a meeting that involved 6 people in a room in Washington, D.C., in which a few voices were the loudest. And as a consequence of that, a definition that stood untested for 42 years emerged, in which the mean PA pressure was reported to generally not exceed 20, and that if it was above 25 millimeters of mercury, that meant that a patient had pulmonary hypertension. And that really was what stood, as I mentioned, for over 4 decades. But as we know, the implications here, of course, is that anything at or above this threshold from this historical meeting must be abnormal, implicating that anything below that were, by definition, normotensive. And I think as cardiologists in this audience, we're accustomed to the concept of gradients and continuum of risk. I'm not sure we would really refrain from contemplating an ICD implantation in a patient who had 29 seconds of sustained ventricular tachycardia as opposed to 30. And so I think as I started to get organized and enter into this field, I became more interested in the continuum of risk related to pulmonary hypertension. And as Dr. Bott mentioned, I was fortunate to engage what is, I still think, our biggest and most well-described individual patient level national cohort through the VA system. And this is a reflection of data collected at 83 cardiac catheterization labs across the US and the US territories. This is a few years ago now, about 10 ago. And you can see here that in this cohort of 21,000 patients, we were able to model the relationship between mPAP as a continuous variable to all-cause mortality. And one of the immediate observations that we made was that when you refer back to the classical definition of pH at or above 25 millimeters of mercury, of course, you could see an important increase in the adjusted hazard ratio for mortality of over 2-fold compared to the referent, which in this case we used 10 millimeters of mercury. But that importantly, this risk rose at a level which at the time was considered to be normal. And so this began an interest in focusing on where risk really emerged in the context of cardiopulmonary hemodynamics. We learned that patients with an mPAP level of 19 to 24 were at 22% increase in all-cause mortality. This was a cohort that represented 23% of the entire study population in this case, suggesting that not only were these patients vulnerable, but they represented a substantial percentage of the patients that we see in day-to-day clinical practice. And this observation that contemplated a wider hemodynamic range was one that could play out in a number of different cohorts. This is the results of a meta-analysis demonstrating that whether you looked in Europe, whether you looked in other databases, particularly when you looked at sex balance databases, you still came to the same general conclusion that patients with mild PH were nonetheless at increased clinical risk. And this is important because we know that patients who have mild pulmonary hypertension are much more likely to be encountered in clinical practice. These are lung samples that were isolated from patients from the original clinical center experience with hypertrophic cardiomyopathy who died from a different reason, but based on the complete phenotyping efforts at that time, had hemodynamics measured and had lung histopathology done at the time of autopsy. These samples, in some cases, are over 50 years old, but we were able to recruit them from offsite pathology libraries that still kept good records around the intramural program of the NIH. And you can see clear evidence of fibrotic and hypertrophic remodeling in distal pulmonary arterioles in these patients, even though their mean PA pressure level was on average about 25 millimeters of mercury. And this implies end organ injury in the context of mildly elevated PA pressures, which could be corresponded to large echo studies indicating that slight changes in the right atrial or right ventricular geometric configuration, and certainly in patients who have evidence of impaired systolic function on the right side, are at elevated risk for increased mortality. So we have a hemodynamic continuum that matches evidence of histopathologic remodeling in the affected organs of the distal pulmonary arterial circuit, and that in those patients with elevated pathogenic changes to the right side of the heart, there is a clear and consistent increase in mortality. So this really drives us to understanding what the totality of the hemodynamic range of risk is in this disease. And we would go on to subsequently chart this out in a number of different ways, going back to the VA CART database to reinvestigate what the relationship is between pulmonary vascular resistance and all-cause mortality when you consider patients who had a lower MPAP threshold to define pH, now focusing around 19 millimeters of mercury. And you can see that the classic threshold that we're all taught in medical school of 3 Wood units is certainly associated with a substantial hazard risk, but actually this risk begins at a much lower level of about 2 Wood units. And as a consequence, even after you start the process of subdividing through sensitivity analyses and segregating out and bifurcating different parameters, including pulmonary artery wedge pressure, you are left with the same observation that this is a disease that is defined by MPAP and pulmonary vascular resistance levels that are much lower than what was considered to be diagnostic of the disease just a few years ago. And ultimately, this is translated into a change in the hemodynamic thresholds, as Dr. Bott had mentioned, in which we now use in clinical practice 20 for MPAP millimeters of mercury and PVR threshold of 2 Wood units. And we can sort of categorize patients based on their post-capillary or combined pre- and post-capillary pH predilection when we think a little bit about how those different variables align in combination. But the point here is that this story isn't really meant to think about expanding the hemodynamic range by 5 millimeters of mercury or a pulmonary vascular resistance level by, say, 0.8 Wood units. It's important clinically to people that practice in PH. But the main objective here is redirect focus to mild disease. How can we start to think about where to put our attention when trying to initiate early interventions that may be pharmacotherapeutic or it may be preventative in nature as a way to mitigate the elevated rates of morbidity and mortality that are associated with this disease? And this is obvious when you start to, the importance of this is obvious when you start to get into what the data are showing us about pulmonary hypertension. If you look at the REVEAL registry, which is a national referral cohort focusing on patients with pulmonary arterial hypertension, you can see that there is on average a 2-year delay between symptom onset and diagnosis, which follows the nonspecific symptom presentation that many of these patients have to begin with. That's shortness of breath, some dizziness, exercise capacity decline. And as a consequence, most providers are thinking more about other causes of disease. When we look at the AMBITION trial, which is our best clinical trial enrolling incident patients with PAH, these are patients that are diagnosed de novo and then immediately enrolled in a clinical trial. You can see that the average MPAP level here approaches 50 millimeters of mercury with a PVR of almost 10 Wood units. So I'm talking about thresholds that are way down to the left of the scale, okay? But they're important clinically because they're associated with morbidity and they affect a lot of patients. We're capturing patients way at the end of the spectrum. So we have got to do a better job at understanding how diagnosis is unfolding. Well, it would be helpful to point to evidence that diagnostic approaches in clinical practice are complete and that they are reproducible and that they are comprehensive. But these data from the VISN-1 in the VA system in New England, which I did again under the supervision and guidance of Dr. Bott, indicated that a small minority of patients who have severe pulmonary hypertension suggested by echo are in fact moving forward into the diagnostic algorithm. These are definitely not unique data to the VA system. This is probably as good or better than what we see in most systems when we look at non-selected patients. And we also know that when we take a look more carefully at those that are referred to expert centers, a third tend to be misdiagnosed and over a half are inappropriately treated. So this is a disease that in some ways suffers from belonging to two specialties, cardiology and pulmonary medicine on the one hand. And as Dr. Bott mentioned, that was one of the first steps I took when I went to the VA was to partner with pulmonologists. I learned a lot from their point of view on this disease, their approach to clinical medicine. I had to relearn a lot of pulmonary medicine, but I think it made me a more worldly citizen when it comes to the approach to clinical diagnosis in PH. But not everybody has the time to do that. And so we have to think a little bit about novel strategies moving forward that can help mitigate the diagnostic gap and help to improve the identification of at-risk patients in a systematic way using tools that we have. So we know that in MI and in stroke and in other diseases, public health campaigns have been extremely effective. And there's no question that we could do a better job in the PH community of messaging what it means to have pulmonary circulatory diseases to general practitioners, to primary care doctors, and even in some cases directly to patients. We also know that we fall short when thinking about associated diseases that drive pulmonary hypertension as a possible pathway for multidisciplinary clinical care. I had a number of conversations with the fellows today who were exceptional, and I encourage this line of thinking. Systemic sclerosis, rheumatology clinics, infectious disease clinics, liver disease clinics harbor a substantial number of cardiopulmonary and cardiovascular disease patients, but they oftentimes will go under-recognized until they are advanced in their symptomatology, not just with PH. This is a huge opportunity to build multidisciplinary programs that can identify and capture patients early. And of course, getting into the weeds a little bit about what the criteria are for right heart catheterization, there's probably some room there to go to improve the way in which we identify patients who are at risk. But today, and this cartoon I'll mention was a figure from a paper we wrote about 5 years ago, in which we were really thinking hard at that time about how AI was going to come into focus and how it could be important in this disease. And so what I want to talk about for the next balance of the presentation is where we are on AI technology from the lens of clinical applications. And we'll use pulmonary hypertension as a way to describe that story. I know I'm preaching to the choir in some ways because I'm already familiar, in part through conversations I had this morning, with the excellent work in the AI sector that's already ongoing here. So I'll try to put my spin on this in the way that I see where we are now and where we need to go, recognizing that everybody in this conversation has a little bit of a different starting point. So I'm going to try to break some of this down in terms that I hope we can all get behind. The first point I want to make is that it's not a secret why ECG was one of the original diagnostic tests to be the target and the substrate of AI analysis. In part, it's the most standardized diagnostic test in the world. If I get an ECG here, it should generate exactly the same pattern as if I got the exact same test in California, or even at altitude, or even somewhere else in the southern hemisphere. It's probably the most reproducible and precise test that we do. It's also one of the most commonly done diagnostic tests. By some estimates, it's performed 300 million times in a year across medical practices just in the US. So the first approach is to think about the ECG the way we learned it in medical school. This is pattern recognition. You see ST segment depression in a sort of downsloping conformation. You have this RS prime morphology that I could never remember, to be honest with you, and that's supposed to tell you RVH, okay? I think we have a lot of opportunity to deploy mathematics and quantitative assessment using segmentation. And this is exactly how the AI algorithms have focused on interpreting these patterns in a more contemporary and sophisticated way. We're looking at subtle perturbations in the tracing, and we're observing the way in which those subtle perturbations may be used to associate with a ground truth, a diagnosis that's made by catheterization, or say a clinical event, in which case we're observing a hospitalization or a mortality event. Now, that was the first generation of AI approaches in ECG. We're learning more about the opportunities to bring in harmonic transformation of these signal pathways, and even using color-coded spectroscopy as a way to transform ECGs to understand how normal signals translate into a predictable and homogeneous color pattern, whereas disorganized signals that may reflect subtle aberrancy in conduction or subtle aberrancy in the way the amplitude of a signal across an ECG profile is captured through disorganized enhancement. And of course, this leads us to a more precise quantitative approach in which we can think a little bit more beyond the idea of playing the memory card matching game that we probably all did to some degree as children, and trying to match a pattern with a diagnosis, and instead thinking a little bit about all of the subtle permutations that live between those recognizable patterns, which we know is at a logarithmic, and even depending on how you look at it, potentially a scale-free system. Now, to do this, of course, we need a way to break all this down. It's one thing to generate a lot of data. It's a whole different ballgame to have a system to understand how to filter the pattern recognition. And this is where we get into some of the machine learning approaches that iteratively over time can develop an experience in the way the algorithms are interpreting information and iterate that to improve the diagnostic yield. So I'm not going to get into a lot of the mechanics around how the mathematics drives that, but suffice to say, if you're starting with 100,000 or 1,000,000 ECGs and we're thinking about a segmentation pattern, you must have an approach like this that reduces those permutations into a way that ultimately can link a specific output with a specific and clinically actionable independent variable. So the key concept to take away from this approach is that we're looking at structured data input. We're trying to fit that model to the data that you have, and then that is meant to generate quantitative outputs in a way that moves us much further beyond the game of matching. And of course, this is played out in a number of permutations. These are data from Hilary Dubrac at the Mayo Clinic, which has been at the forefront of operationalizing at a system level ECG-enabled AI analysis. She led a team that analyzed a training set from the Mayo Clinic and validated later in the Vanderbilt University Medical Center database, and generated a number of encouraging receiver operating characteristic curves demonstrating a substantial area under the curve for the early diagnosis of PH in patients that may be at risk, but for whom definitive diagnostic data was not available because it hadn't been ordered, and it was not even to be contemplated because there was no necessarily a reason to be thinking along those lines. And so this is an important consideration because we're thinking a little bit about moving into an era where AI in the right context can potentially be leveraged to scratch below the surface and understand what diseases our patients may harbor in a way that captures them early and generates guidance in a reproducible and reliable way. And of course, it's not just ECGs. We're starting to learn about how different commonly ordered tests, chest X-ray, right ventricular echocardiographic parameters, and even sonographically active stethoscopes now can be used to measure, in that case, acoustic signals transformed to harmonic patterns, as I showed before, and then generating what is, I think, an encouraging, if not preliminary, prognostic relevance. So this sort of describes a little bit of the first phase of AI in clinical medicine. However, unlike what we think about in the middle of the night when it comes to medical or surgical emergencies, computer scientists are thinking about other dilemmas and problems to try to fix. So this is the great blueberry muffin chihuahua face challenge that kept computer scientists at the very top of their game awake at night for many years, I'm told. I'm not one of them. And of course, the obvious question is, can we develop a computer algorithm that separates out the face of a chihuahua from that of a blueberry muffin, even though they look a lot alike? And that's where we welcome the more generative AI models. These are the large language models, the chatbots, the multimedia approaches that really operate off of a prompt-based approach. So we've all probably in this room used ChatGPT. I was in Ireland not long ago. One of my favorite songs is the hymn Peggy O. I listened to it from the Grateful Dead as well. And I thought it was Irish. It's not. So I asked the ChatGPT, is there an Irish version of Peggy O? It turns out it's Scottish. And I think the point of the matter here is to articulate that you are prompting the system, and the system, the code, is mapping text to meaning that's been trained over hundreds and hundreds and thousands of elements, which we're learning more and more may include, of course, disinformation or inaccuracy, which we can talk about in a little bit. Now, this approach has been summarized beautifully by Howell and colleagues in a JAMA paper from 2024 that talks a little bit about AI 3.0, focusing on how these foundation models that drive large language model technology into the fold can be used for the purposes of a wide range of clinical operations, including writing assistants and scribes, with the perils identified as well, including false positive signals in the context of hallucinations and other errors. Now, when these kinds of text-based approaches were mapped to visual entities so that the two data inputs could be combined, the Chihuahua blueberry muffin problem was resolved almost immediately. And so we're now at a point in time where, based on the depth and the breadth of the training models and the conversion of text to other outlets, media like images, it is possible to think more broadly about how these prompt-based strategies can be helpful in the context of clinical research. And that gets us to what is, I think, our greatest asset and the data strength that will define clinical research operations, at least from a hypothesis generating standpoint, if not from a decentralization of research standpoint, which is the electronic health record itself. Now, we've all interacted with the EHR. Sometimes it's been our friend, sometimes it's ruined our days when it's difficult to manage. But what we all would agree with is that it is the record that collects and maintains all of the information about our patients. And it has essentially two broad buckets in which that can be classified. Structured data is everything in tabular format. That's typically our lab values and other administrative or diagnostic codes. That's great. It's easily accessed. So the operators that work within the firewall of a medical system that have the appropriate IT capabilities, they can access this information, they can pull it out. But at the end of the day, it's interesting, it only includes a small amount of data. The real story is in the unstructured data elements right now. That includes all of the reports of the tests that we order, echo, right heart catheterization. It includes the patient notes where the patients are telling you what's actually happening. It includes all of this other information that's not in tabular format. This is where we really want to be putting our efforts, but until now, there was no effective way to extract, isolate, and analyze this information, in part because it follows an unstructured pattern. So the way I write a note could be different than the way somebody else writes a note. And of course, if you're in one hospital, that doesn't mean that it's being done the same way as any of the other hospitals in a medical system. So you come up across a logistical problem pretty quick. And enter the opportunity for large language models to harmonize these unstructured data sets that may exist in a wide range of formats and generate information that in turn is actually usable. And this is work that comes from Washko and Rahagi at Brigham and Women's, where they started the process of using large language models to build a template that could extract key data from right heart catheterization reports. And in this study, it was primarily focused on the methods, the computational approaches to assemble this approach. But it also was an important starting point because it really got a lot of people in the field focused on how large language models could be important in turning this sort of unharvested asset of data for our patients into something that's usable. So this slide shows a summary of the University of Maryland Institute for Health Computing. This is one of the projects that I helped to co-direct. It's a $100 million initiative that's funded by Montgomery County, which is where Bethesda, Maryland lives. The Empower Foundation, which is a strategic initiative that interfaces different campuses across the University of Maryland system. And recently, Senate Bill 376, which Governor Wes Moore in Maryland signed, that commits a certain amount of funding to this academic enterprise. Now, our focus, of course, is transformative research, but we also, as an equal objective, want to use computer science to build public-private partnerships and expand the biotech and life sciences ecosystem. So it's a little bit of a sort of a change from the classic academic model. We're really trying to use the resources that we have to expand out our capabilities and to build partnerships with companies that may benefit from our resources and to build out the economic growth of the environment. And we have a six-center model. We have applied AI, immersive visualization, bioinformatics, population health, real-world evidence and adaptive clinical trials, and therapeutic target discovery. And this may sound sort of desynchronized, but it's actually meant to create a very vast pipeline of analytic and technical capabilities that can manage most kinds of problems that come at us from the health and human disease space. So as a principal partner, the University of Maryland at Baltimore and the University of Maryland at College Park have a partnership with the University of Maryland Medical System. Now, this is, in my view, a very powerful map. This is the state of Maryland, of course, and the University of Maryland Medical System is the largest hospital-based provider in the state. It takes care of about 1 in 4 patients and has clinical operations in 23 out of the 25 counties, all tied together through a common instance of the electronic health record. That means that we're able to analyze data on about 2.8 million patients, this is outdated, and about 19 million patient encounters with over a trillion data points that are readily available at the Institute for deploying large language models for training and for extraction and assembling digital cohorts. So it's true that we could characterize these patients using classical terms like race, but at the Institute for Health Computing, we're really focusing more on trying to understand what the socioeconomic, demographic, and geographic parameters are that drive health and human disease. And that's a particular strength of our operation because we have neighborhoods and segments of, say, Baltimore City that are defined by poor health outcomes, which are characterized by urban communities. And we also have areas in the Eastern Shore and the Tidewater region that are also defined by poor health outcomes and limited access and accessibility to healthcare. So we see that in population dense regions, and we see it in rural regions as well. And this is one way that we can use the electronic health record of a medical system to understand a broad and generalizable database. And we started the process of showing how this can be powerful even by demonstrating the effect of changes in the air quality on acute cardiopulmonary disease burden. So Mary Maldorali was a pulmonary critical care fellow who approached me when I first arrived, which was around the time that the Western Canadian wildfires of Alberta had emitted a smoke plume that traveled 2,100 kilometers and penetrated into the eastern seaboard of the United States. We were looking outside of our window. She asked the question, I can't see anything. Could that potentially be bad for our health? And I said, well, let's look at it. And so we partnered with some of our atmospheric modelers at the Institute. We confirmed that the trajectory of the smoke that we were looking at had in fact moved from in a transcontinental way from Western Canada all the way into the portions of Maryland that are highlighted here. And then we focused on EPA records and identified 6 specific days in which the air quality in the region was substantially abnormal compared to control days. So we're converging lines of evidence. We have news reports. We're looking at the outside with our own eyes. We have geospatial satellite tracking. We have evidence of smoke covering in different regions of Maryland. And we are confirming on a day-to-day basis the EPA information from Baltimore City that there are 6 days in June in which there's a substantial spike in the PM 2.5, which is the aerodynamically harmful particulate matter dimension, the diameter, that is important to the air quality in the region. And this was associated with a 20% increase in the clinical encounter rate for heart and lung disease over these 6 days compared to controls. So we were able to demonstrate that the medical system was a valuable resource to access that information about what was happening on those 6 days specifically, driven by the evidence that we had in hand. So that sort of pipeline is a little different than other reports on the importance of the environmental perturbations that can influence heart disease. That's, of course, been shown. But what we were trying to do here is make the case that we have a way to get granular information in a very specific way. So with that in hand, we turned our attention towards the concept of pulmonary hypertension, and we looked at 17,900 right heart cath reports across the 12 hospitals in the University of Maryland Medical System where there is a cath lab. There are over 11,000 unique patients in the system. And we built a 3-agent large language model. So that allows one agent to perform a task, a second agent to perform a task independently with cross-referencing. So the second is not dependent on the first, so that if there's a problem with the first, it doesn't get carried on to the second. And likewise with the third. And ultimately, we were able to identify and characterize the accuracy of how we pulled information from these right heart catheterization reports and demonstrated that we could do this with almost 100% accuracy across the board. So you think a little bit about what that means right now. If we were interested in doing this study hand to hand, we would have to go through 17,000 reports and document exactly how accurate this was. We were able to generate these accuracy tables and use as the ground truth a synopsis of about 100 charts that were abstracted. And then based on the performance measures, we could trust the large language model to perform well moving forward. So this allows us to know who our universe of patients are with pulmonary hypertension, heart failure, whatever clinical phenotype is referred for right heart cath. Our interest, of course, was in pulmonary hypertension, but this is a powerful tool for boosting clinical trial enrollment, for understanding how to decentralize clinical research so that it is a proposition all have an opportunity to participate in, as opposed to those who are able to travel to a center, which is a major barrier in many cases. And then focused on those patients that had a missing mean pulmonary artery pressure. So we found about 550 cath reports, including 507 patients that did not have an MPAP level. It's a kind of a scary thought for a pulmonary hypertension person, because it means that 507 patients were referred to right heart cath and left without the sentinel value that's needed to make the diagnosis of pulmonary hypertension to begin with. So we wonder whether we're starting to see opportunities here to maybe get ahead of the delay in diagnosis curve if we could automate the diagnosis itself somehow. And to do that, we assembled a machine learning-based algorithm that took information that was available in the chart, in the report that was extracted by the large language model. In this case, the pulmonary systolic pressure and diastolic pressure. And then we created an algorithm that could impute the mean PA pressure with exquisite accuracy. And we partnered this large language model approach with the machine learning approach to create a pipeline that can extract information and ensure that a complete diagnosis and an accurate diagnosis is made for 100% of the population. We confirmed across a number of sensitivity tests, again, looking at different subgroups and across the ground truth with hand review, and this was done and led by Dr. Katarina Zader at the Institute for Health Computing, and learned that among those for whom an MPAP level was absent, the imputed level was associated with about a 2.7-fold increase in mortality over 3 years. So patients were leaving the cath lab without the right diagnosis because they didn't have the MPAP level recorded. This approach identified that, it restored that level, and that among those, about 75% had pulmonary hypertension, and the level of pulmonary hypertension that they had was at a level associated with substantial increase in mortality. So the overall sequence and the opportunities that we think we have here, we have a way to automate some of the diagnostic approach. We think this is timely and scalable, and we think that this is a way to interact with different medical systems together. And so this is just one portal of entry into how AI in medical system and electronic health record data sets could potentially be useful to improve care and to standardize research programs across different medical systems. Of course, we're not alone. This has been going on, although I will say that, that this is probably one of the first efforts across a large medical system that's truly balanced in terms of its socioeconomic, demographic, and geographic representation, and in which a novel diagnosis is imputed by two algorithms. So just a final closing word on where we are on AI in medicine. We get asked a lot, usually with very anxious eyes, what is going to happen to us all when it comes to AI in medicine? I think the important first step to take is to recognize that not all AI is the same. We have different kinds of AI. We're comfortable with AI helping us to spell check. That's a little bit different than the proposition of using AI as a clinical decision tool that makes a choice for a provider. So I think the first is to recognize that a lot of what we're talking about falls on a continuum. And I think to get more comfortable with the continuum, there are three pieces that are important, and this will be central to the way we approach this issue at Circulation. We're asking for disclosure on the use of AI, especially in the research itself. We need to understand which features are dependent on AI. That itself is not disqualifying, but if we don't know what's been done, we need to understand where the person in the loop played a key role so that we can feel comfortable about where and how valid the data set is. The second is the explainability piece. We're all familiar now with probably too many risk calculators and too many algorithms. What we really need to know is what's driving the decision making, especially in AI. You wouldn't go and get snacks off the shelf of a grocery store if you didn't know what was in it. I'm not sure we should be relying on AI that also doesn't have the appropriate labels about what is being used to drive the decision making. And then we're asking for transparency in reporting. We need to get a standardized approach, which is already in motion by a lot of the organizing and governing boards of academics. So in conclusion, AI is here and medicine must be ready. I think we're all sort of there already, but I just wanted to make that point because there's no real reason to think that we should be circumventing it completely. We just need to know how to contend with it head on in a way that's responsible and in the best interest of the patients. I think AI-based clinically actionable diagnostics are getting close for prime time. They're not quite there yet, but we're getting ready. And I would say this is an exciting time, provided that we have the right guardrails, we have the appropriate oversight, and we maintain a doctor in the loop or a provider in the loop so that there are appropriate checks and balances to the way in which automated technology is being used, being overseen, and being monitored. Okay. Just a shout out to some of the key people that were involved in the AI data and concepts that were presented here. Flo Du lent me her the Chihuahua and blueberry muffin example. Pratyash is more in the therapeutic development space. I mentioned Dr. Zader, and Dr. Goodman has reported many key articles on policy in the New England Journal and in JAMA about how we should be thinking about diagnosis as a tool from AI. So appreciate your time. Thank you.
Well, that was really outstanding. Earlier in your career, you redefined pulmonary hypertension based on the hemodynamics, and now perhaps we'll redefine it with AI. Really, really fantastic. Before talking about PH, just given your incoming role as an editor, I was looking at Tom Maddox's slide there graphic from New England Journal. What should the journals do with respect to AI? Most college students are using AI to write their college essays right now, either without the permission of the schools. So it's only a matter of another generation or two before it becomes like a spell checker or a grammar checker where everyone's doing it. What do you think journals should do with respect to using AI for the writing process, and what they should allow, and then the peer review process as well? Again, a lot of peer reviewers, either with or without journal permission, are doing it already.
Well, I appreciate the question. So I'll make a few comments. First, again, I think disclosure is very important, and the extent to which the use of AI can be cross-checked with 100% certainty is itself its own moving target. But we need to build partnerships with our constituents, which are the authors in some cases, and with the readers and the patients themselves, to know that the information that we're publishing is accurate and that we know where it's coming from. Now, in the first phase of the transition, I'll say that we have seen a number of authors disclose the use of AI. So I feel generally comfortable that it's being disclosed as a yes or no. The extent to which that is happening with respect to how much AI is being used is a process that we're looking at to try to standardize. Again, matching the use of AI with the function is very important. If we're talking about advancing a clinical support tool that relies on AI and may be actionable or perceived as actionable by a reader, we have to scrutinize that and understand where the code is, what the reproducibility is, to the best that we're able to, so that it can be generalized and recapitulated. The review process is a separate issue. You mentioned Tom Maddox. He's joining us at Circulation. He'll be leading a two-part role, one focusing on the use of AI in the research, and one focusing on how we should be using it in the review process. Putting papers into ChatGPT or other publicly available AI sources as a reviewer is extremely dangerous. It would be among the cardinal sins that you could commit, because that then puts somebody else's protected work into the public space. You may not see it like that. This is not a victimless crime. We have evidence of that already, not in my own personal oversight, but in stories that have been circulated among editors about how that's an important issue that needs to be addressed first and foremost. So our policy, of course, is against that. Can we unilaterally stop that? This is something that I think we're all contending with one way or the other.
Yeah, really very thoughtful answers from an editor. Dr. Maron, any questions or comments or reflections on this?
What a fantastic lecture. I learned so much just looking at and listening to your talk. But as you said, AI is here, and we need to embrace it the best way possible. I can tell you and speak on behalf of the ACC as the new president of ACC, and we are absolutely looking at this. There's several task forces, presidential task forces, that are looking at AI and how we're going to incorporate that into how we function at ACC, but also how we use some of those data that we currently have and house at ACC to serve, but also how
Audrey,
important it is for us
or do you let her know that?
how to manage
Hold on
it.
a minute, here's my
Certainly the,
brother, because
workload
I'm
of
not
the,
good with.
workforce will be decreased by better use of AI, but navigating that and understanding how we could still be a very important, having an important active role as physicians in caring for patients but using AI to expedite some of those is gonna be absolutely great. But I will come back to tell you that, we are at a dilemma in terms of how we will embrace it. It is moving at a speed much faster than we could evaluate it. And that is the issue that we are facing at the college, but also all of us are facing. And we see, and I fully agree, thank you for bringing up what you're doing at the journal, very much in line with how we see it in the college. So it's nice to see that that's an important agreement. But I think that the current generation of our colleagues are using AI at a speed much faster than we are even having the time to evaluate it and say, what's the best way forward? I'm certain that just the other day, I was asked to be a co-author on a paper of a meta-analysis, which I found it to be actually dangerous to have some of this data that haven't yet been published that are being used into the meta-analysis to get an answer. But the author, who's an early career person, had not disclosed that they had used, but it was very clear to me that it had to be because they got the information somewhere. So it's a dangerous area. And I guess my question to you is, where do you see the future? Because you're running an entire decision medical center. Here we have the neural computer just a block away. We're using a lot of these data, and in fact, ACC is looking to partner with centers like this or University of Maryland in terms of what we could do and how we could tap into some of the resources that you have. So where do you see this kind of culminating into something extremely positive and not taking away the roles of physicians as they are in terms of overseeing the work that's happening?
Yeah, I appreciate the comments and the question. From a clinical actionability standpoint, the future of AI will grow as a partner to the provider. I think it's important, and I mentioned with the fellows earlier that the standard right now is that the clinician is responsible for the outcomes. So we're not in a position to outsource key decision making right now to anything else. We have to take responsibility for that. So I think it's an important consideration because at the end of the day, you serve as the ground truth, and your relationship with different AI applications may be very synergistic. These are tried, tested, validated, and proven tools that maybe are giving the users a very secure sense. That's a certain kind of an experience. But to those that may over-rely on untested technology who are responsible for clinical decision-making, they are still held to be responsible for the outcomes. So I think that's probably the best that I can do right now in the sense that the technology will grow, the partnership hopefully will strengthen, but at least for now, the buck stops with the clinician. And that's, at the end of the day, the most important part for the patients. And I think that's the anchoring and tethering feature to the discussion.
Yeah, no, really great question and thoughtful answer. Any other question, Dr. Ferry? Any PH related questions?
I like the power that how important is to be right. And like echoing what you were saying, I have been in some of the NIH reviews, and I know one of the problems, for example, is creating this context that doesn't work. So how do I do it? Do I know what the ground actually? And because they are all busy, sometimes they don't have time. So they find it. So even I with what the person is working on is always going to be particularly challenging. Trying to decode where is the ground.
I think it's important to remember that these large language models are trained on huge amounts of data, which we now know includes false information to a certain degree. It does not make them useless, but it does serve as an important and sobering reminder that it remains incumbent on us, the people that are doing the research, the clinicians that are making decisions, to clarify and confirm that the information you're using is real information. It has consequences.
Whether they have the opportunity to, because they have probably more experience, they have time, learn. I think the new information might simply put it in. Very interesting. Lots of talent.
Absolutely. Yes, Dr. Dang.
Yes, I think this was a great presentation, a very forward-looking discussion. I think we have to try to be a little bit ethical for months. I think doctors have been, one can say, cornered a little bit in many aspects. Setting the standard by which this machine, the terminology may be, are held in order to prove that they are high quality, in order to assist us, credibly, you can see, is very important. But if they're not, we don't set it up from the organization. What is it that makes this machine at the level above par, let's say? What is that? If it's not set up prospectively, I feel that anyone or whoever is not abiding by the Hippocratic oath, let me put it out, may have ulterior motives, and then all of a sudden there is either accepted or 200 or 50 or whatever pages, forms, authorization if you don't want to accept it, and the liability is all with you, and the profits are all others. And we have to be very careful about it. It's one thing to say, sure, we are ultimately responsible, and the one click versus 20 pages of suggestion, then that's not fair. People are going to slow down super slow with whatever this may mean also later about the difficult training, for the next generation. But we all know, we just lead it left or right that the open utilization of ChatGPT or other things like anyone, it causes the brain to go like not functioning a little later. One can feel those things, what they mean, if they become reality, and it's too late. So I think prospectively, for our organization, the medical organization, need to be strict, set up guidelines. If that means excess on those accuracy-related research, well, so be it. As, in the end of the day, it's like a spinning ticket for all discoveries, and they have to meet a path that we will be comfortable as opposed to kind of feel later on or possibly.
Yeah, I appreciate the comments. And one of the big topics under discussion right now is how accurate do the AI models need to be? So if you're automating a diagnosis and it's 98% accurate, is that enough? What about the 2% that's not accurate? Is it off by a small amount? Is it off by a huge amount? Is it off by enough to reclassify a patient? And what about how that compares to what we're already comfortable with? There's, as you know, false positive, false negative rate with any test. So is the AI code being held to a unique standard? We're already comfortable with modest positive predictive value and negative predictive value of, say, a chest X-ray. It gets done 100,000 times a day in a hospital. So, I think some of this is unsettled, and your point's well taken to be involved and to try as providers and clinicians to take ownership over how policy gets set. I think that's exactly right.
Any other questions from anyone? I like, George, how you slipped in the Hippocratic Oath there. No, for those of you that aren't familiar, Dr. Dangus actually had the Hippocratic Oath folks here from Greece about a week or two ago, where it all starts. Any other questions from anyone? Anything? In that case, well, let me take this moment to thank you, Dr. Maron, for coming in on behalf of the Mount Sinai Fuster Heart Hospital. Let me present you with this plaque that says the faculty and fellows of the Mount Sinai Fuster Heart Hospital express appreciation to Bradley A. Maron, MD, for outstanding teaching, wisdom and expertise as a Simon Dack, MD, visiting professor and memorial lecturer. Thank you again so much for coming. And for anyone interested, there is a reception outside for the next 30 minutes or so. So if you want to come chat with Dr. Maron, please do so. Thank you all for coming. Thank you for those of you on Zoom.
You sure?
Yeah.